Hi everyone, and welcome to my podcast, Liver and Guts. I'm Dr. Kash Gupta. I'm a gastroenterologist and hepatologist in the UK. And today I wanted to talk about a really important topic for the Western world in particular, and that is fatty liver disease. The 2 billion person epidemic that no one is talking about. So I think it's really important to go through this. It's a huge topic. There's so much research being done on it. It sounds simple, but it's way more complex than we think. If it was so simple, we wouldn't have as big a problem as we do. And this affects a large proportion of the population. And if it doesn't affect you, it will affect a family member at some point, and probably for a long period of time. So what if I said to you that the most common form of liver disease in the world, affecting about 4 in 10 people that we know of at the moment, and that figure seems to be rising, and that figure is globally, tends to be more of a problem in the Western world at the moment, although it is a problem in developing countries, and it remains dramatically underdiagnosed and undertreated. And what if the condition that we're talking about is the leading cause of liver transplant, still lurking in millions of people, and they don't know about it? And they may not know about it until it becomes too late, unfortunately. Because it doesn't cause any pain, it just causes damage and inflammation until it's too late, unfortunately. So today we're diving into a condition called fatty liver, NAFLD, non-alcoholic fatty liver disease, and now we've termed it metabolic dysfunction associated steatotic liver disease, or MASLD, M-A-S-L-D for short. And it's a condition I believe represents one of the most important yet most neglected public health challenges in our time. And crucially, we're going to explore how your gut health is intimately connected to your liver health, a relationship that's transforming on how we understand and how we treat this epidemic or pandemic. And I'll be honest, as a hepatologist, I've watched this epidemic unfold over the past 2 decades at least. And what concerns me most isn't just the disease itself, it's that liver health and gut health just don't seem to receive the attention they deserve in the broader conversation about longevity and metabolic health. We see a lot of discussions online now with podcasters, medical professionals, YouTubers, and they will talk about how metabolic health is important, cardiovascular risk is important, and they will mention that you get fatty liver disease and just brush across it. But it's a key marker of survival. The liver sits at the metabolic crossroads in everything we do. The gut is the closest partner to it. Yet this relationship remains underappreciated in mainstream discussions. So the name change that matters, we should talk about. So before we go any further, let me explain why we're using this new name, MASLD. In June 2023, a multi-society Delphi consensus officially retired the name NAFLD, non-alcoholic fatty liver disease, and replaced it with MASLD. And this change has profound implications for how we understand and approach this condition. The old name defined the disease by what it isn't, so it's non-alcohol related. The new name defines by what it is, a metabolic disease. And this isn't just semantics. The new terminology explicitly requires the presence of at least one cardiometabolic risk factor, elevated body mass index, prediabetes or diabetes, hypertension, high blood pressure, elevated triglycerides, or low HDL, raised LDL cholesterol. And this shift acknowledges what hepatologists have known for years, that MASLD fundamentally is a systemic metabolic disorder that happens to manifest in the liver. It's not just a liver disease. It's a whole body problem that reflects broader metabolic dysfunction. But at its core, when the liver becomes dysfunctional, everything else can fall apart. So understanding this connection is crucial. The liver doesn't exist in isolation. It communicates bidirectionally with fat tissue, skeletal muscle, the gut, and the brain. And when we address MASLD, we're really addressing the entire metabolic ecosystem. And that's exactly what this podcast is going to be helpful for. It's important to know that understanding what goes on with your liver is going to help you understand what risk profile you have, and when your liver is improved, you know that other things can improve as well. And I'm talking about things like gut health, things like cardiovascular risk, things like cancer risk, things like diabetes. So you can find things wrong with you metabolically, but if you don't address the liver, then other things won't fix. And it's not necessarily just a case of losing weight, although weight loss does help. We'll go into that going forward. Next question. The numbers that should stop you in your tracks. So we talked about a few figures earlier on where we mentioned that there's about 2 billion people with this condition, 38%, 40% of people have fatty liver. And I didn't mention actually that there was a 73% increase in prevalence between 1991 and 2019. And actually I'm currently just trying to write a paper looking at some of those up-to-date figures. And in fact, the problem with liver disease is it's rising, and in particular fatty liver disease, amongst other things. I might call this fatty liver disease just for simplicity and for short until everyone picks up the new term MASLD. But MASLD, fatty liver, NAFLD, they're all interchangeable at the moment. So it's a global epidemic. Let me share some numbers that illustrate the magnitude of what you're dealing with. MASLD, fatty liver, now affects approximately 38% of the population, the adult population. That's over 2 billion people. To put that in perspective, that's more than populations of North America, South America, and Europe combined. And the trajectory is alarming. The prevalence has increased from 22 to 37% between 1991 and 2019. There's a 68% increase in less than 3 decades. So you're talking about a 70% increase over 30 years. We're not dealing with a stable condition. We're witnessing an accelerating epidemic that shows no signs of slowing down. And it's scary. It really is. But here's where it gets really relevant for listeners. If you have type 2 diabetes, your risk isn't 30% or 40%. It's close to 60 or 70%. And the relationship between diabetes and MASLD is a bidirectional one. It's not just you get diabetes and you get fat in the liver. There are dysfunctional issues likely with the liver that contribute to this metabolic syndrome. And it seems to be synergistic. So add 1 plus 1 to get 2. It's 1 plus 1 is 11. There's an increase in the way things worsen when you add those two conditions together. It's a vicious cycle, and it can be difficult to break without intervention. And perhaps the most troubling, between 35 and 38% of patients with fatty liver who undergo liver biopsy have what we call MASH. And that's something we call metabolic dysfunction steatohepatitis, the inflammatory progressive form that can lead to cirrhosis and liver cancer. So cirrhosis of the liver is permanent scarring of the liver that you can't reverse. And so, some studies support the figure as high as 63% in selected populations. So let me just let that sink in for a minute. Nearly 40% of people who have a fatty liver will have inflammation, actual inflammation in the liver. You've got fat deposition, fat causes the inflammation, and that inflammation leads to scarring. So about nearly 40% of the people with fatty liver will have inflammation in the liver. So if you imagine 40% of the population, and that's a conservative 2 billion, I think, but out of 2 billion, another 40% will have inflammation of the liver. So that's, what is that? 200 million times 4, roughly, so 800 million people have got inflammation of the liver. That's a huge population. And it gets more complex than that. So there is something called the lean MASLD paradox. Essentially, that challenges our assumptions and talks about how fatty liver can occur in lean individuals. And we call that lean MASLD. And it affects about 7 to 20% of all MASLD patients who have a normal body mass index. And this isn't a rare exception, it's a substantial subset of patients. There was a Lancet meta-analysis which showed some sobering information. Patients with lean MASLD actually had a higher risk of all-cause mortality than those with overweight or obese MASLD, with a hazard ratio of 1.61, which is kind of counterintuitive to what you might expect, essentially saying that people with fatty liver who are slim have a higher risk of dying. So they're a higher risk population, the kind of skinny fat population. So they may look thin, they may have a normal BMI, but in fact their organs are doing badly and they're doing badly metabolically, and they're at higher risk than some of the fatty population. I think if we were going to be really strict on that criteria, the guys with a BMI of 20 to 25 seem to be about the second highest risk. The highest risk people are the morbidly obese population, above 45 BMI or so, at least 40 BMI. So if you're morbidly obese, you're the highest risk population, but the second highest risk tends to be that lean MASLD population. So why might this be? We think it's because lean MASLD often goes undetected. Nobody looking for liver disease in someone with a normal weight. They don't address the issues, and these patients don't fix the expected clinical picture, so they slip through the cracks, often until their disease is advanced. And additionally, lean MASLD may represent a distinct metabolic phenotype with different genetic susceptibilities and gut microbiome profiles. So it may be specific to that population, but these people don't feel it, they don't know it. I've seen slim people, professionals in the healthcare industry that didn't know they had it. They thought, I'm slim, I'm good. And I know people who have died of cirrhosis from it. So it's really something to look out for and at least get yourself screened on. But what actually kills people with fatty liver, here's something that most people don't realize. The number one cause of death in MASLD isn't liver failure, it tends to be cardiovascular disease. Now that's not to say that cardiovascular disease is the more important thing here. There is important evidence now showing that the rate of cardiac events is still, so the total number of cardiac events is still the biggest cause of death in, for example, the UK and USA. But the rate at which that's rising is a lot less, in fact, coming down compared to fatty liver disease and liver disease. So the rate of liver disease, although smaller in number than cardiac events, is rising faster. And fatty liver tends to be an independent risk factor for things like heart attacks. The liver and the heart are intimately connected through their shared pathways of insulin resistance, inflammation, lipid dysfunction. And MASLD is an independent risk factor of heart attacks, even after adjusting for traditional risk factors. And this is critical. Liver-related mortality increases exponentially with fibrosis and scarring of the liver. So liver events occur almost exclusively in those people with advanced fibrosis. There was a prospective study found that liver-related events in 9.1% of patients with advanced fibrosis compared to 0% in those without. So this underscores why identifying fibrosis early is so important. It fundamentally changes your risk profile. So part 3, your gut is talking to your liver through the gut-liver axis, a very important concept. And that's why it's essentially why I started the Liver and Guts podcast, because I do believe that the gut and the liver as well, is absolutely central to your health. And all these things that we're seeing happen, like heart attacks and cancer, they are, of course, increased risk as a result of our lifestyle issues. But there is a bottleneck at what goes on with the liver. And that's where all the bad stuff seems to be churning out from. And the entry route appears to be the gut. And when the gut is damaged, you get a leaky gut, or you're eating the wrong foods, alcohol, etc., or you don't do enough exercise, all those things, they do cause problems centrally via the gut and the liver first. And then everything else is affected downstream. And I think what's happening in medicine now is that we're seeing all these things that are downstream, we're seeing the effects, and we're looking at all these studies and these associative studies to see, well, what is it? And we're getting strong associations with lifestyle factors, although I don't particularly like the term lifestyle, and I'll talk about that perhaps much later. And we're trying to figure out, well, if you do that bad thing, this bad thing happens, cut away that bad thing, and this is okay. And that certainly works to a degree. Part of the problem, I think, is we don't often know what is bad and what is good, and there's so much confusion out there. But understanding, I think, the mechanisms by which things go wrong help you make the right choices, and that's what I'm trying to do. Teach people what's going wrong. So your gut is talking to your liver. So more than just fat in the liver. MASLD isn't just fat in the liver. It's more than just type 2 diabetes is sugar in the blood, for example. This oversimplification does a disservice to our misunderstanding and can lead to inadequate treatment approaches. The pathogenesis involves a complex interplay of what researchers call the multiple hit model. And you kind of hear that in various mechanisms, but let me try and go through it. So the key players include hepatic lipid accumulation, oxidative stress, inflammation, mitochondrial dysfunction, endoplasmic reticulum stress, and crucially, dysregulation of the gut-liver axis. I know that all doesn't necessarily make sense. It's just a bunch of words, but please hear me out. So each of the hits contributes to disease progression, and they interact with each other in ways we're still working to understand fully. So let me explain the gut-liver axis in a bit more detail, because this is the core of what the Liver and Guts podcast is all about. And it's where some of the most exciting research is happening. And I do have some friends that are doing amazing research in various parts of the world, and certainly in London, Oxford, etc., Cambridge. The liver and gut are anatomically and functionally connected through the portal vein. So there's a big vein that connects the gut to the liver. It's called the portal vein. And everything you absorb from the intestine, nutrients, toxins, bacterial products, metabolites, good stuff, the bad stuff, it all passes through your liver first via the portal vein. And the liver serves as the body's central processing unit, filtering and metabolizing what arrives from the gut. So you can imagine all those processes I talked about, they occur in the liver, and when they occur wrong, that's when you start getting damage, and that's how you get knock-on effects with metabolism, cancer, etc. Let's talk about the leaky gut. So it's taken a long time for this kind of information to come through, and leaky gut to be recognized as a true condition. There was a good review I studied which describes what happens when this system breaks down. In MASLD, we see increased intestinal permeability, what's commonly called the leaky gut, there was a meta-analysis of 14 studies showing that MASLD patients have significantly increased intestinal permeability compared to healthy controls. And when the gut barrier fails, bacterial products like lipopolysaccharide LPS, also called endotoxin, leak into the portal circulation. LPS activates toll-like receptor 4 on Kupffer cells, which are these macrophages in the liver, triggering inflammatory cascades involving TNF-alpha, interleukin-6, and the inflammatory inflammasome. So this isn't just a theory. Studies have shown that plasma LPS levels are significantly elevated in fatty liver or steatohepatitis patients. And these levels correlate with markers of gut permeability. And we're seeing the molecular evidence of this gut-liver inflammation go haywire. Next thing to talk about is the microbiome signature. Multiple studies now show consistent microbiome changes in MASLD, reduced bacterial diversity, depletion of beneficial bacteria like Faecalibacterium ruminococcus and Coprococcus, short-chain fatty acid producers, and overgrowth of potentially harmful bacteria like E. coli and Enterococcus. But here's what fascinates me the most. There's now evidence that some gut bacteria produce ethanol, actual alcohol, through fermentation, and patients with MASH have high levels of blood alcohol with even higher concentrations in the portal vein. And researchers have shown that transplanting stool containing ethanol producing Klebsiella pneumonia into mice causes inflammation in the liver or steatohepatitis. That's a fascinating experiment, taking the stool from adults, putting them into mice with fatty liver and causing inflammation of the liver. And this suggests some patients with non-alcoholic liver disease may actually be experiencing the effects of endogenous alcohol production from their own gut bacteria. So you're getting drunk on your own gut. I think it was called Brewer syndrome. It also suggests the distinction between alcohol and non-alcoholic liver disease may be more blurred than we previously thought. A humbling reminder of how we still have to learn a lot about the gut-liver relationship. Next topic I want to talk about was bile acids, the gut-liver messengers. Very important topic, underappreciated, but coming out in the research literature now. The gut-liver axis also involves bile acid metabolism. Bile acids aren't just digestive detergents, they're signaling molecules that regulate metabolism through receptors like FXR, TGR5, and in MASLD, bile acid composition and signaling are altered, contributing to hepatic lipid accumulation and inflammation. And this is why some emerging therapies target bile acid pathways. Understanding the gut-liver axis opens up entirely new therapeutic choices that go beyond just caloric restriction or weight loss. And it's why taking care of your gut is taking care of your liver. I will add to that, we don't know. People may ask, is there permanent damage that can be done to the gut? I don't think we know that yet. The good thing about the gut is it is highly regenerative. If you, I do procedures such as colonoscopies and endoscopies, and we often see real damage from inflammation, inflammatory bowel disease, ischemia, polyp removal, scarring, ulcers, things like that. And when you get therapy, the gut can regenerate very well. Segment 4, the simple tests that could save your life. So I'll mention a few straight out the bat, but FIB4 fibroscans are essentially the tools that we need to use. So why early detection changes everything? Both the European and American guidelines now recommend systematic screening for MASLD with liver fibrosis in high-risk populations. So high-risk populations, they're very obese, by BMI, risk factors such as diabetes are important groups, hypercholesterolemia. So all patients type 2 diabetes should be screened. This represents a major shift in clinical practice. We've never really done that before. And we're finally recognizing that waiting for symptoms means waiting until it's too late. Really hard to do. I've been asked to try and do that. I don't know how we get the workforce to screen entire diabetic populations in a city. But why is early detection so critical? Because MASLD and even MASH are largely reversible in the early stages. Fibrosis can regress with appropriate intervention, but once cirrhosis is established, your options become much more limited. The window for intervention is wide in early disease, but narrows considerably as fibrosis sets in and advances. Two-tier screening approach. So essentially, the recommended approach uses a simple two-step process that can be implemented in any clinical setting. And understanding this could generally change your health trajectory. So step one is a FIB-4 score. And this is a simple calculation using the ALT, AST blood tests and the platelet count. Costs nothing beyond routine blood tests that are likely already being done. And the calculation is straightforward and available through online calculators. If the FIB-4 is below 1.3 or 2.0 if you're above 65, because the test has been validated in people below 65 and above 35, you're at low risk for advanced fibrosis, and it can be monitored in primary care with periodic assessment. This simple cutoff stratifies the vast majority of patients appropriately. Having said that, step two is getting a FibroScan. I think if people just went to FibroScan, that's reasonable as well. But step two is the FibroScan liver stiffness measurement. There are various tools to measure FibroScan. We can talk about the machines more and more, but the main one is something called a FibroScanner, which is like an ultrasound machine, but even less invasive. And it uses sound waves passing through your liver and coming back and timing how long it takes to measure liver stiffness. And it develops a score, which is essentially a surrogate marker of how much scarring there is. So if your FIB-4 is elevated, then you should really go on to get the FibroScan. And it's a painless test, non-invasive, takes a few minutes to do. And if your liver stiffness is below 8 kilopascals with an interquartile range of less than 30% error rate, then it's a reliable reading, and below 8 is good, you're fine. But for whatever reason, you may need to be kept an eye on. Above 12 to 15 suggests advanced fibrosis. That's a broad term, a broad calculation. It depends on the cause of the liver fibrosis. There's different reference ranges for different causes. And so you'll need to get an opinion from a specialist if there is any evidence of scarring of your liver. So it's not complicated. It's something very simple. GPs and other doctors should be able to request these. I certainly have given access to my hospital. But the high-risk patients are those with type 2 diabetes, obesity, metabolic syndrome, polycystic ovary syndrome, and those with persistently raised liver enzymes. Family history of cirrhosis, liver-related mortality, genetic conditions may warrant fibroscans if there are issues such as hemochromatosis, alpha-1 antitrypsin deficiency. And just remember, don't let the lean MASLD paradox fool you. Don't let a normal BMI make you think that you're fine. And I'm not trying to scare. This is the truth. This is the real data that's coming out here. Segment 5, treatments that actually work, from lifestyle to new drugs. So foundation of diet and exercise really does work. So let's start with what we know well, lifestyle intervention. Evidence here is unequivocal and should be given to everyone. Studies tend to show that 7 to 10% weight loss can resolve MASH in up to 90% of patients and improve fibrosis by up to 45%. So if you do it well, then you can get really strong benefits pretty soon. You let it go, they come back. Another study demonstrated resolution of steatosis in up to 97% with lifestyle changes just alone. So a low-calorie diet, 500 to 1,000 calorie deficit, plus 150 minutes of moderate or 75 minutes of vigorous exercise per week, Everyone talks about low-carb diets. Mediterranean diet specifically has good evidence base, rich in the good foods, good for your gut. Olive oil, fish, nuts, fruits, vegetables, whole grains, no processed food, or at least limit processed food and added sugars. And importantly, this diet is excellent for your microbiome. And that's not just about weight loss, it's about muscle mass, it's about cancer risk, it's about actually preventing the scarring of your liver through toxins going through the portal vein. Exercise has benefits independent of weight loss. You can exercise and lose a fatty liver, or improve a fatty liver and not lose any weight. Both aerobic and resistance training both show reduced fat content even when body weight doesn't change dramatically. Various mechanisms work in here, mitochondrial function enhanced, but also improved insulin sensitivity. And I would say that there's been lots of to and fro about muscle mass and resistance training being better than aerobic. I don't think that's necessarily true. I think when it comes down to the practicalities on an individual basis, it's about what you can sustain. So if you're someone that could sustain resistance training a lot better and found that you did a shorter period of resistance training, but did that consistently over 10 years, you're going to be in a better position than the person that, you know, got up to running a marathon 1 year and then dropped it for a year afterwards. And certainly those are topics that I'd like to touch on, because I don't think it's all about what exercise you're doing necessarily. I think people are generally missing the point when it comes to living a healthy life. And yeah, it's easier said than done to tell someone to lose weight. Sustained change in lifestyle is generally challenging in our modern food environment. But even the modest weight gains, 5%, produces meaningful 30-40% fat out of your liver. So, and I think going for perfection is difficult here. I don't think you need to go for perfection. Good news is that liver is remarkably responsive. Unlike some organs where damage is largely irreversible, the liver has tremendous regenerative capacity. Early intervention yields disproportionate results and benefits. So it's true what they say about the liver. It is very regenerative. There is a limit though. There's also a new drug revolution. We've all heard about the GLP-1 drugs, and I could do a whole thing on that, pros and cons of that. I don't think they're the panacea. I don't think they're going to fix everything. We're clearly not relying on lifestyle alone, which is a shame, but we're witnessing a pharmacological revolution in MASLD treatment as well. And that's fundamentally changed the therapeutic landscape. So new drug called resmetirom or Resdifra, first FDA approved medication for non-cirrhotic MASH with moderate to advanced fibrosis, and MASH is the inflammation version. So if there's advanced scarring of the liver due to fatty liver disease, it's a thyroid hormone receptor beta agonist that improves both the steatohepatitis and fibrosis without requiring weight loss, and it works directly through hepatic lipid metabolism. So the fats in the liver reduces the fat content in the liver. And this is significant because it offers a mechanism independent of fat loss. August 25, semaglutide, marketed as Wegovy for obesity, was approved for non-cirrhotic MASH with moderate to advanced fibrosis in America. And the phase 2 trial showed MASH resolution in 59% of patients on the high dose compared to 70% on placebo. So there was an effect from placebo as well. And if placebo works, I would take it. Weight loss averaged 13%, but the hepatic benefits appear to exceed what would be expected from weight loss alone. Sorry, I didn't mean to say that placebo is superior to the drug. The drug was superior to placebo. All I'm saying is there was some weight loss in placebo as well. We also have strong evidence of pioglitazone. That's been around for a while for fatty liver. We never really used it that well. It improves insulin sensitivity. It's a diabetic medication. MASH resolution occurs in 51% versus 19% with placebo in the PIVENS trial. And whilst there are concerns about weight gain, fluid retention, limiting its use in some patients, it remains an option. But I don't think we're really using that as much anymore in favor of the GLP-1s. GLP-1 receptor agonists like liraglutide, semaglutide are showing consistent benefits across multiple trials. Mechanism involves weight loss and direct hepatic effects through improved glucose metabolism, reduced lipid toxicity. And the pipeline is remarkably rich. Dual GLP-1 GIP agonists like tirzepatide are showing even more impressive results. So tirzepatide is on the horizon, certainly. And there are other drugs, FGF21 analogues targeting hepatic lipid metabolism, PPAR agonists, FXR agonists. So I'm just kind of churning out names here, which aren't really useful to you unless they're available. And certainly some of them are available in the US, but not so much in the UK. But for the first time in history, we have pharmacological tools that can meaningfully alter the trajectory of liver disease. And the question is no longer, can we treat MASLD? It's, will we identify patients early enough to benefit from these advances? You can imagine the drug companies are very keen on us to try and screen as much as possible so we can find as many patients for them to use the medication. And I'm not against pharmacology. We need it. We certainly need it for a lot of patients to help combat this. We're not going to. But I do think that trying to manage things through not just necessarily your lifestyle, but through system changes around you, whether that's at a high level from the government level or individual, I think those would be in many ways better than having to use pharmacological agents, of course. And the pharmacological agents need to be used when they're not working. But the scary thing here is that it's rising so rapidly. It would be really difficult, I think, to control everything pharmacologically. So finally, what do you need to know? Key takeaways. Know your FIB4. Consider a FibroScan. Act early. If you have any cardiometabolic risk factor, elevated blood sugar, central obesity, high triglycerides, low HDL, hypertension, you should know your liver status. You should definitely know your liver status. Blood test, FibroScan. This is particularly important if you have type 2 diabetes where the prevalence approaches 70%. Ask your doctor about FIB4. It's a simple calculation. You can get your blood results and do it yourself. MD Calc works. Consider the FibroScan. I have a very low threshold getting FibroScan. If someone wants a FibroScan, I get it arranged. We're supposed to say, do a FibroScan if your FIB4 is elevated, fine, but you know, FibroScan is more sensitive. Don't wait for symptoms that may never come until cirrhosis is established. Liver is a silent organ. You don't feel any of this. It does not complain about damage until it's right at the end. Gut health. Think about your gut health. Really important. It's not separate from your liver health. They're intimately connected. A diverse, healthy microbiome supports liver function. A dysbiotic gut can drive liver disease and cancer everywhere. And there are so many products that people are offering right now. We spent, I remember, decades trying to figure out, does diet have anything to do with these conditions? And it is pointing towards, obviously on hindsight, that these dietary changes that we've had over decades are contributing in a negative way. But here's the bigger picture. To anyone that's interested in longevity and metabolic health, liver health, gut health, we appropriately focus on metrics to live longer like VO2 max, grip strength, lean body mass. That's all good. These are important markers on health span and longevity. I focus on those as well. But while we're optimizing these parameters, we should also be paying attention to the liver and the gut, which together form the metabolic engine of the body. You don't build muscle without a good functioning gut and liver. You do not. You do not absorb stuff. You do not process stuff. So it is a non-starter. You are going to be impaired if your gut and liver are impaired. Ever seen people who lose weight massively, who've got active inflammatory bowel disease? That's the extreme end. Have you ever seen how difficult it is for people with liver damage to improve their muscle mass? They just waste away. So those are extreme ends, but milder versions occur. The liver integrates signals from across the body and coordinates metabolic responses. The gut provides the fuel and the signals. You cannot achieve optimal health span whilst ignoring these organs. It's time we brought the liver and the gut prominently into our conversations about health optimization and longevity. The good news is that both organs respond remarkably well to intervention, unlike many chronic diseases where damage is largely irreversible. Liver disease, when caught early, can often be reversed. Gut health can be transformed within weeks. This is a message of hope. And I'll close by saying thank you for joining me today. I'm Dr. Kash Gupta from the Liver and Guts podcast. Please subscribe if you found this helpful and share it to anyone that you think might find it useful. We'll talk again. And in the meantime, you take care of your liver and guts. Take care. Bye-bye.